Good evening, everyone. My name is Ben, and I'm a health educator here at the Hospital Research Foundation Group Arthritis. And it's my pleasure to welcome you all tonight to our webinar, Arthritis and Pain, with Professor Lorimer Moseley, AO. I'd firstly like to start by acknowledging the traditional custodians of the lands of both which myself and Professor Moseley are presenting today. We pay our respects to the Aboriginal and Torres Strait Islander elders past and present, and recognise their ongoing connection to lands, waters, and culture. We honour their histories, traditions, and living cultures, and commit to working together for a better future. Now, I would like to raise that Professor Moseley has said that he's happy to answer some questions at the end, and that the question and answer feature is open the entire time. So if there is something during the presentation that you think might be good to ask, I do recommend that it's good just to pop that in straight away so we can get to those at the end. I will also say that this webinar is being recorded and that a recording will be sent out to everyone who is registered at a later date. Now, for those who aren't aware of Professor Lorimer Moseley, he's a globally recognized pain scientist, clinician, and educator. He's the Foundation Chair in Physiotherapy and Professor of Clinical Neurosciences at the University of South Australia and was appointed a Bradley Distinguished Professor in 2021. Lorimer's groundbreaking work has reshaped the understanding and management of persistent pain globally. He's the founder of Pain Revolution, a not-for-profit movement dedicated to ensuring all Australians have access to the knowledge, skills, and local support to prevent and overcome persistent pain. Lorimer has also led as the establishment of UniSA's Innovation, Implementation, and Clinical Translation in Health, or the Impact in Health, and was director from the inception until 2023. Lorimer has authored over 400 scientific papers, numerous books, a wide range of educational content, including website articles, webinars like tonight, blogs, videos, anything that's out there in the health education world. Lorimer's probably done it. He's also presented at numerous national and international conferences, and his achievements have been recognised with the Award of Officer of Order of the Australia, or AO, for his distinguished service to pain science, education, and physiotherapy. We're incredibly lucky to have Lorimer on tonight, and I'll hand over to him.
Thanks, Ben. G'day, everyone. That's that's great. It's quite a mouthful, isn't it? All that palaver. So when Ben asked me if I'd be happy to do this, I was really keen to find the opportunity because arthritis is no one in this webinar would need reminding of this, but it's obviously a massive problem. And the reason that it affects lives is because it's painful. And I'm very interested in pain, which is a bit weird. I recognize it's a bit weird, but I'm interested in a whole lot of feelings that make us do things to protect ourselves. And what we're realizing more and more from a whole range of types of science is that often we are being protected by feelings when we don't need that extent of protection. And to me, that's highly fascinating. And being someone who for 8 or 9 years was disabled by what I would describe as brutal back pain, and then being someone as a physiotherapist who was trying to help people in that situation, and then becoming a neuroscientist and I guess exploring why the brain does stuff and how the brain does stuff. Pain seems like the coming together of all of those sort of lived experiences. And hopefully I can surprise you a little bit tonight with some of the stuff that we now know about pain. But I guess my main objective will be to just trigger a bit of curiosity about the expanding mix of things that we can do when we're experiencing pain, and particularly pain that we're experiencing on most days or all days, and what we can do to reduce that and to reduce its impact. So, like Ben, I'd like to start by acknowledging that of this great Southland, I love putting this map up when I speak at conferences overseas and introducing people overseas to the true cultural complexity and ancient history of Australia. Ben and I, and some of you, I imagine, are on Kaurna land. I too pay my respects to First Nations and Aboriginal people. And Ben was talking about connections, and as a scientist, as a biological neuroscientist, the the explosion in our understanding of how connected we are to each other, to the environment around us from a molecule perspective is really cool, and it's quite relevant to inflammatory conditions like arthritis. I'm in the knowledge generation and dissemination game. So, my job is to move the field forward. And I know probably as much as as anyone, perhaps, that the brain can't remove information that might be relevant to survival. So, everything that I do will be done from a complex brain that's considering what's in it for me. So I think you should be considering what's in it for me when you decide what to do with what I'm talking about. So part of that is for you to understand that I get royalties from any books that I mention, and I do mention books. I've also been supported to go to conferences or accommodation at conferences from these companies. Some of these companies have even paid me money to do things for them. So the most relevant to today is probably Reality Health, AIA insurance, and the book royalties. Often when people talk about their disclosures, their conflicts of interest, this slide is on the screen for about a second, but I think it's really important because uh, I'm selling information. I think the information is true on the basis of scientific method, but you've got to understand what the bias might be from me. So I want you to think about these two questions, and I want you to dig deep in thinking about it. How does pain work? And as you think about it, I want you to just try and work out what the process might be from the moment that you tread on a sharp tack or something like that, uh, to the feeling that you get, that sharp, intense, possibly panicking or distressing pain in your foot. How does that actually work? Or think about if you're someone who suffers from persistent low-level back pain. Think about how that actually works. And often when people think about that, they think about nerves sending messages that are recognized by the brain. Then I want you to think about your own experiences of pain. Ask yourself, what's the point? What's the point of pain? Think of the most recent experience you had when you were hurting. Why were you hurting? I find those questions really interesting. It feels like this. If we were talking about back pain, it feels like it must work like this, that there's detectors in your back, and those detectors detect pain or damage or something like that, and they send a message up into your brain, and your brain receives the message and thinks, oh, that's what's happening down there. I've got back pain. And that's exactly what it feels like. And I think that's why it's so effective. Pain is very effective at making us do things differently. If we were to ask the question, how does it actually work? Well, it's a bit more like this. So what I've tried to do here is to just give you a sense of it's bloody complicated, actually. It's highly complex. And this makes it both very difficult for us to understand all pain experiences, but it also opens up a whole lot of opportunities for managing pain better or treating people with pain. What I've done with this drawing is I've gone to the literature. This took me a long time, this drawing. I did it about 2 years ago. I went to all of the published scientific articles I could find and looked for experiments or projects that clearly showed something to change pain. And then I've put them all into that drawing with little lines as though they're neurons, if you like. And so everything you can see there has solid evidence that it influences pain. So let's construct it a little bit more slowly. So it's complicated. So the brain is thought to receive billions of nerve impulses every second, way too many impulses for it to actually process it all and understand what's happening. We also know that the whole time we're moving, and actually even as we're not moving, we are receiving messages from our joints, from our muscles, from our skin, from our ears, from our eyes about where we are, what are we doing, and how our body is aligned. Those data are coming in all the time. Our beliefs about what is the problem, what is arthritis, our understanding of how arthritis works. We know that there's a range of beliefs that affect how much something hurts. So our beliefs and understanding influence pain. Our current environment influences pain. Where we are influences pain. What we do about it influences pain. Our general health influences pain. And this is particularly relevant for arthritis. And our past experiences and our other feelings influence pain. So how do we break all this stuff down, and how do we determine what's the most important stuff? If you're someone who's suffering from pain on most days, I imagine you don't want to do a 3.5 year neuroscience degree in order to understand fully how pain might work. Uh, uh, what's a spoiler alert? If you did do a 3.5 year neuroscience degree, you probably wouldn't be that advanced on your understanding of pain. And that reflects how much our understanding of pain has changed over the last 2 decades. We've done a lot of work trying to identify what are the key concepts that are helpful to learn if you're someone who's disabled by pain. What what aspect of this massive body of literature and scientific knowledge is worth knowing? And we've published a lot of papers on this, but I want to just tell you what we came up with in the end. So this is a 10-year project, a dozen, at least a dozen different studies, over 500 people with pain or have recovered from pain. And we've come up with what we call the 4 essential pain facts. So in the next 30 minutes or so, not even that, uh, I'm going to try and give you enough understanding of the 4 essential pain facts that will help you craft a journey towards recovery, or help you help someone in your life who could benefit from that, or safeguard you a little bit from subsequent development of chronic pain. You might even learn something that will help you cope at the dentist, or when you twist your ankle, or pick up a box that's a bit heavier than you thought it was and tweak the ligaments of your LAFT. Now, if you don't know what a LAFT is, LAFT stands for Living Adaptable Force Transducer. Used to be called the disc, used to be called an intervertebral disc. But actually, the intervertebral disc is nothing like a disc. The only place that it looks like a disc is on a CT scan, on a CAT scan. You can't slip them. You really can't take them away from the vertebra. They're very closely related and connected with the vertebra. So next time you hurt your back, even if the back pain is absolutely brutal, you might be able to grab something from the next 30 minutes and use it to your advantage. The first essential pain fact is that pain protects us and promotes healing. I just want you to think about that phrase, because at first landing, you will be completely comfortable with that idea. Pain protects us and promotes healing. When you think about it a bit more deeply, it might start to hit up against other understandings you have. For example, when we are injured, I believe we are not in a lot of pain because we're injured to tell us how bad that injury was. We are in a lot of pain to protect the injured tissues while they heal. So we now in pain, in modern pain science, we have phrases like pain does not detect damage, pain protects us from damage. And the more you think about this, the more likely you are to start to be a bit annoyed or to disagree with it. Now, we've got a lot of experience understanding that dissonance. And that dissonance is really important for you to move towards a more scientifically accurate understanding of how pain works. But instead of going there, let's just talk about the metaphors. So I want you to think about this metaphor. It's called the cliff top metaphor, metaphor of the cliff. So here's someone that in this, this is out of a book that I wrote, and remember, I get royalties for this book. I wrote this book with David Butler and Haley Leake and James McCauley and Ben Wand. It's called the Resolve Back Pain Handbook, and it presents this metaphor for pain as the fence on the top of a cliff. So this person here we call Lucy. Lucy's standing on top of the cliff, grabbing a great selfie, standing very safe, but being able to enjoy the view. And the thing that keeps her safe is the fence, and it's got a stop sign on it. And in the side-on view at the bottom, that fence will be aligned in a position where Lucy can enjoy the view, but she's not at risk of injury. Where the injury occurs is if she falls off the cliff, if she gets too close to the edge of the cliff. And that position of the fence, the distance between the fence and the cliff is what we might call a pain threshold. So you might know someone who you think has a very low pain threshold. One way of using this metaphor is that their fence is a bit further from the cliff. They've got a bigger safety buffer being offered by pain. You might see yourself as someone with a very high pain threshold. In that case, your fence might be particularly close to the cliff. If you were an elite performer, you're playing AFL footy, you will probably have a fence for running around. When you're running around and doing things, the fence will be quite close to the edge of the cliff. So you don't want any wasted safety buffer. That's the metaphor that we use to understand how pain protects us, keeps us safe from injury. When we are injured, and this is often the thing that makes it difficult to understand this essential pain fact. When we are injured, everything changes, and it changes very quickly. And the way that it does that is just totally cool. It's totally cool. The neurons that detect a change in the environment in our body immediately change if there is an injury or if there is significant inflammation in that area. That's very relevant to different kinds of arthritis, because if there is inflammation in the area, then those detector neurons that just tell you about changes in the environment that they sit in quickly change their properties, so that now you don't have to do very much at all to activate a signal that says something big's changed here, even though something small has actually changed. And the way we capture that in the metaphor, if you look at the bottom picture first, immediately there is this massive safety buffer being offered. Pain occurs a long way before tissue damage, or in this metaphor, the fence is now so far from the edge of the cliff that you can't even enjoy the view. And now you can see Lucy pretty depressed about the very bad photo, the selfie that she's going to be taken. She can't see the view. So pain protects us in the images on the left, and it promotes healing in the images on the right by stopping you from putting loads through tissue that needs to heal. So while the tissue is compromised, the protection system is completely wound up. It's not just what it feels like. And this is one of the really powerful nuggets of learning, particularly around arthritis, that we have a system to keep us safe that we call pain. And it's a feeling that we have in our body, and that feeling is unpleasant and it makes us do something to stay safe. In the back end, behind the curtain, are what we call the protection musketeers. And those musketeers are using movement. That's the musketeer on the left at the top there. It says, "I'll stop you moving your ankle." He's talking to the bilby. So in all of our books, we have a consistent character of a bilby that's involved, because we love bilbies and they're endangered. So in this particular scenario, the bilbies hurt their ankle, and the movement musketeer is able to immediately change the way you move. Now, if you've got long-standing arthritic knee, you will know that you move differently. And if you go and sit down in Pitt Street Mall here in Adelaide, or over in Whyalla near the cafes, or Mount Gambier along the main street there, and just look at people walking, you will see people with, every now and then someone will walk past with just a tiny limp. And you'll know that their motor system is currently protecting them. They may not be in pain, but their motor system, their movement system, is protecting them. It might be what we've labeled there, the I for the immune system. The immune system is what makes something swollen and sensitive and possibly red after an injury. And then there's the hormone system. That's cortisol and adrenaline that changes the way a lot of your systems work. And they sit there adjusting their levels all the time. So they will adjust their levels according to what the entire system says is the current need for protection. The bilby down the bottom there is saying injuries are so painful because the need for protection is much higher. This is how pain promotes healing, and that's essential pain fact. Pain protects us and promotes healing. The second essential pain fact is this, that persisting pain or persistent pain overprotects us and prevents recovery. Now we're getting into the situation where you might have pain on most days for more than 3 months or so. We would call that chronic pain. And in chronic pain or persistent pain, systems change. So if you remember the very complicated drawing of how pain works, it was 50 years ago, almost 50 years ago, that a discovery in a rat showed us that at this little location in that very highly complex system, the neural networks, or the nerves that conduct messages and process information, become sensitized. They increase their sensitivity. And they do that when pain persists. And that was a big discovery. It was called central sensitization, and some of you will have heard of central sensitization. Not that much later, about a decade later, the same thing was discovered here, up higher in the nervous system. So the first one was in the spinal cord. This is in a part of the brain called the thalamus, and the same increase in sensitivity of neurons, and now we say neural networks, has been identified up there. So we know the system is increasing its ability to produce pain. And what that means is that you will get pain when there is less danger. And you will get more pain than you would have got before the system started to sensitize. So it occurs in a couple of places. It also occurs here, a different part of the brain, slightly to the forward of the thalamus. So it's occurring in a few places. It occurs here as well, actually. And here, in fact, it occurs all over the place. These changes in how neurons are working can occur all over the system. And what that means is that as pain persists, persistent pain, it overprotects us. We end up having pain when the tissues are not in as much danger, or maybe in no danger at all. It feels much worse than the tissues actually are. And this is a really, really difficult thing to get your head around because it feels exactly the same. So why does that happen? Well, we blame this property it is my favorite biological property, and we call it bioplasticity. And many of you would have heard of neuroplasticity. So neuroplasticity talks about the brain that changes, the nervous system that changes. Well, bioplasticity just refers to changes across all of our biological systems. So if you look at that list on your screen of examples of bioplasticity, if you play the piano often, you get better at playing the piano. If you walk more often, your leg and back bones get stronger. If you increase your gardening, you develop calluses on your hands. If you rest more, you lose muscle bulk and bone and ligament strength. If you start avoiding social contact, you forget how to be around people. You become less effective at social contact. If you move more, you get better at moving. If you swear more at the pub, you find it harder not to swear at work. And if you have pain for longer, then you have pain more easily. when things are not quite as dangerous. The processes that cause this to happen are exactly the same. So we're in a challenging situation. If you look at this metaphor of the cliff, you can see that Lucy is having exactly the same experience in both of those scenarios because the fence has moved a long way from the cliff. So she's getting pain a long way before her tissues are in danger. On the left, it's because of the injury. And the injury changes sensitivity in the tissues. On the right, it's because of changes inside the central nervous system. And that happens with persistent pain. And we call those changes together, we call them pain system hypersensitivity. So the longer you have pain, the more pain system hypersensitivity you will develop. These two things feel very similar. So when you've got pain system hypersensitivity, it feels like you always have an injury. But actually their causes are very, very different. And the longer we keep trying to fix the pain system hypersensitivity around persistent pain as though it's an injury, the longer it will be before we get on to the true causes of it. Another metaphor that we use that some of you might relate to, if you've got a reasonably new car, you might have the little beepers that go off when you're getting too close to a pole. This describes both of the first two essential pain facts. The first one, pain protects us. That's when the beeper's working well. So you go to park your car, and as your car gets closer to the pole, the beeper starts going off, and that keeps you from hitting the pole. Just take a moment to think of how stupid it would be if you had a beeper that only went off after you hit the pole. That would be like pain serving to tell us we're injured. However, pain serves to stop injury, to protect us, and to promote healing. So the beeper goes off before your tissues become injured. The lower image there grabs the second essential pain fact, that persisting pain overprotects us and prevents recovery. That situation in the car would be if you see a nice car park and you put the car in reverse, and before you've even moved, the beeper starts going off. Now, in that situation, you're never going to hit the pole, but you're not going to be able to park your car. So in that way, persisting pain, it overprotects us and it prevents recovery. The third essential pain fact is that many factors influence pain. And I've already given you some understanding of that through that very complex drawing where I went through all the scientific articles I could find and put drawings in for all of the things that we know from experiments and studies influence pain. But I want to tell you about just a couple of experiments that I've been involved with, just because I think they're cool. This is an experiment that I did a long time ago where we recruited supposedly normal, healthy volunteers. Now, I do that because these people have volunteered for a pain experiment. And look at what my computer screen is doing. I didn't even know that that would happen. That was cool. I wonder if I can make that happen again. Oh, there it is. Now I'm getting confetti. Unintended visual gags. These people volunteered for a pain experiment, and that experiment involved a very cold piece of metal being put on the back of their hand under two conditions. One condition, we showed them a red light at the same time. Now, red means hot, and associated with temperature change, it means danger. The other condition, but exactly the same temperature rod, was a blue light. And then we asked them a range of questions, one of which was how much did it hurt? And these are the data. So what you're looking at here is on the left, this is what the pain rating from people when that minus 20-degree stimulus was associated with a red light. And on the right, it's when it was associated with a blue light. Now, if you can see my cursor, hopefully you can see my cursor, and I'm pointing out the lowest score on the red side, which is a horizontal line. So that person had the same pain intensity regardless of the light. And there's another person up there that's quite like that, and one that's quite like that as well. Everyone else has a different response. These people here are idiots. They just don't pick up on the cues that the rest of the group is picking up on. So here's a situation where a cue, a visual cue, has influenced pain potentially to a large amount. Take this scenario. This is not just about pain. So this is a visual illusion. And it tells us that the brain is considering a lot more information than we think it is when it's creating experiences for us. So in this scenario, you should see two grey panels. And what I imagine you can see is that the top panel is darker than the bottom panel. Now, if you can get close enough to your screen, put your index finger in front of your eyes so that you can no longer see this little section of the drawing. You might have to move your finger a bit there, and once you get it in the right location, you will see that those two panels are actually exactly the same shade of grey. So why do they look different? We experience them as different because your brain is doing a whole lot of other groovy stuff, taking into consideration everything you've ever seen before and deciding what's the most likely true situation. And that's in vision. But we know the same thing happens when it comes to bodily feelings like pain. I've just removed the rest of the information on this one, and hopefully you can see quite clearly that they look like a different shade of grey when you compare it to that. What about the things we say or the information we receive from health professionals? I thought this was a fun experiment. There we go. In this experiment, laser stimuli were shone, so it's like a little laser gun shoot, onto the sole of the foot of these supposedly normal, healthy volunteers. And at one location, randomly allocated, one location, the participants were told, your skin's very safe, this is fine to do. On the other location, they said, your skin's slightly thin and it's probably safe to do it. So the difference there was probably. That's the only difference between these two scenarios. And these are the results. So first look at the result in the middle there that I'm putting the cursor around, and that's the pain they experienced in the two different locations. Remember, they're swapping the locations around, so in between participants. So you can't explain this difference by where the stimuli occurred. We can only explain this difference by whether or not the experimenters said, you're probably safe or you're safe. This was a brain imaging study as well, and these people were able to link up parts of the brain that align with that recognition of probably or not. It's not just pain. It's not vision, not just vision. It's also protective reflexes. So here's a cool bunch of studies. These people do experiments where they stimulate the foot and record the size of the withdrawal reflex. So that's the reflex when you put your hand on a flame and you quickly pull it off. They do an experimental version of that. And what you can see here is a participant sitting in a chair with the stimulator and then a recording device recording muscle activity. And then this thing in front of this person's head is a little canister of odor. And they do exactly the same experiment under different odor conditions. So the odors are being put up this person's nose, and they look at the size of the withdrawal reflex. So how big is the withdrawal reflex? Now, when there's no odor, it's on the left, it's the same withdrawal reflex as if there's a pleasant odor. And it seems pretty similar to if the odor is neither pleasant nor unpleasant. But what do you think happens when they use what they called fart spray? So this is a disgusting smell, disgusting odor, and they do exactly the same stimulus to the foot. What do you think would happen? You probably guessed right. The size of the protective reflex is double. This is happening outside of our awareness, outside of our consciousness. So if we were trying to work out all the different influences for you, you will be different from the next person. In fact, you will be different one day than you may be the next day. It's very hard for us to experimentally and methodically go through every single thing that might be influencing one person's pain. So instead of that, we just look at that metaphorical thing in the middle of the drawing that we call the protectometer. And if you spent time on this drawing, you would see all the lines have different colors, or there's 5 colors represented, and they match these different categories of the protectometer. And if all of those sliders go up, then the protectometer is more likely to go past the pain onset level. It's always moving, so this is not only about pain, it's also about these three protection musketeers. So if you get any piece of information that tells you you are in danger, your protection setting changes. And if your protection setting goes high enough into the pain zone, then you will have pain. And we apply the same principles here to other feelings that make us protect ourselves, like anxiety. If you're feeling anxious, or you're feeling frightened, you're feeling hungry, you're feeling thirsty, you're feeling fatigued, we can apply this protective model to that. So now we're encompassing all the many factors that influence pain into one of 5 categories. The fourth essential pain fact is really sitting on the back of the third one, and that is, because many factors influence pain, and because of bioplasticity, this property that we have that can change. In fact, change is inevitable. It's happening right now. I'm working very hard to move your change in the direction I want it to move. We're always changing. How we change is not inevitable. The fourth essential pain fact says, well, because many factors influence pain, there are many ways to reduce pain and promote recovery or slowly retrain your system. Now, in most pain conditions, most chronic pain conditions that we're working with, the 2 main components of doing that involve understanding and movement and loading of your body. Now that might sound straightforward, and your immediate response might be, yeah, well, I've done that and it didn't work, or my partner did that and it didn't work. The thing that people find the hardest is the understanding component of this. And this comes from a book where we talk about 3 components. I'm only talking about 2 here. And the challenge of juggling those 3 components. So we talk about them as though they're balls. And when we look at what's difficult to do here, we've got 12 studies with over 500 recovered consumers, so people who have negotiated a way to recovery from chronic pain, who tell us this, that the understanding ball, or the understanding bit, was the most difficult for me, but the most important. And that's been a really big discovery for us, that people who manage to improve their situation, when we ask them, how did you do it? What did you learn that was most important? They say, well, learning was important. Education. So we're spending a lot of time trying to make that better. And it's all centered on bioplasticity. So if you can read this, and I'm going to get a little bit of help from my glasses to read this, read along with me. This is Albert Einstein saying to Leonardo da Vinci, how do I get better at riding this bike, Leonardo? And Leonardo says, the more you ride, the better you will get at riding. It will become second nature. How do I get better at playing the piano, Leo? Practice, Albie. The more you play the piano, the better you will get at playing the piano. Why is my pain spread and become worse? Well, Albie, the more your pain system makes pain, the better it becomes at making it. So there's not a sign that my body is falling apart? Not at all. It means your pain system is providing a protective buffer much bigger than you need it to be. Says Albie. Any good news? Yes, says Leo. Heaps. By taking a modern approach, you can retrain your pain system to be less protective again, reducing the size of your protective buffer back towards normal. Wouldn't it be great to be a fly on the wall for a conversation between those 2 thinkers? How do we actually implement it? Well, it's not that difficult once you get the hang of it and understand what your influences are. We use the Goldilocks principle. Not too much, not too little, but just right. And that will give us a sense of a sweet zone for change. So there will be amount of movement and loading and other demands on your system. It might be social interactions. It might be stressful people. It might be stressful places. It might even be foods. There'll be an amount of that exposure that is enough to trigger an adaptation, but not enough to flare you up. And in pain system hypersensitivity, the size of that sweet zone, so that Goldilocks zone, becomes smaller. That's a consequence of the changes that happen potentially all across your central nervous system. So you can see here, and I might need my glasses again, it's quite small on my screen, but we hear comments like this from people who are starting to get their head around this new science of pain. And we talk about the sweet zone being smaller when you have persistent pain. This person on the left is saying, is this why I thought I didn't have a sweet zone at all? With coaching, I found it and it slowly got bigger again. Is this why sometimes I flare up doing something I've done a dozen times before? Is this why I find flare-ups hard to predict? That's one reason. What we can say, take it to the bank, absolutely, is that bioplasticity and using the Goldilocks principle, that sweet zone, will produce positive adaptation. How do we do it? Well, we can use the protectometer to make the sweet zone bigger. So the protectometer, you might notice, has DIMS written on it with an upward arrow and SIMS with a downward arrow. DIM stands for danger in me. So on this protectometer, anything in your current environment that tells you you might be in more danger is an orange slider dim. Anything in your current environment that tells you you are safe, we could call a SIM, which stands for safety in me. And when people really get their head around this and using these concepts to slowly retrain their system back towards normal, they start to say things like, I'm a dim sim expert, or I'm using dim sim therapy. It's not easy. And I think a really important acknowledgement with anyone who's got persisting pain is that improving your life is very unlikely to be a quick fix. There's no magic bullet. It's quite likely that it will be a process of change, a journey that will require some hard work, but you get the right team around you, you might find the right coach or supports and guides, and you can start to retrain your system. If you have a progressive disorder, like some kinds of arthritis, uh, or some other disease process, then that adds to the complexity, and that's when an informed coach can be particularly helpful. I'll stop it there. So I've done my 40 minutes. I've actually done 41 minutes now, I think. But I mentioned at the start that I get royalties from books. So here's some books that I get royalties from. But we at this website, that's a QR code, will take you to the website for neugroup.com. They publish all of the books I've been involved with. The top two there are 2 out of 3 patient-targeted handbooks. So these are handbooks, they're quite small and you slowly work through them, and they have exercises, and they help to give you an understanding of those concepts that those hundreds of consumers who have recovered or significantly improved from chronic pain tell us they're the most important things. So those handbooks help you work through that, and then help you to, well, I use the phrase operationalize that. What can you do about that? How do you start retraining your system in a practical way? The books at the bottom, that's 2 out of 3 bigger, more significant books. I've said here, tie these ones to a brick, because Explain Pain and Pain and Perception tend to go missing. People tend to steal them, certainly from GP practices and physiotherapy practices. They're fun to read, but they're a bit more expensive. You might have to get a syndicate together to get one of those. Free stuff. There's a lot of free resources at the website for a charity that we set up in 2017 called Pain Revolution. This QR code will take you to that website, and the 4 essential pain facts. You might have noticed in tonight's talk that there's a little phrase that says learn more, or a PDF. So you can actually click on them and go through a short slideshow, or get some PDFs that will help you understand these essential pain facts. And then ideally, take that new information that you have to a good physio, a good exercise physiologist, or a good GP or psychologist, and say, I want to retrain my pain system back towards a normal level of protection. Tame the Beast is a animated little movie that will touch on some of these things as well. There's interviews with people who have recovered and other resources on there.
That was a fantastic presentation as always. I feel very lucky to have you on and to listen to you speak about, such a complex issue, but we know that one is one of the most common requested ones for these webinars, and unfortunately one of the most common experiences for anyone with any type of arthritis.
Yeah.
So if anyone does have any questions, feel free to pop them in. We've had one come through so far, if you're happy to comment on it. Someone's asking if neurodivergency affects pain.
Great question. And gee, these sorts of questions are coming up more. Uh, yes, yes. But how it affects pain, uh, we really haven't done enough research on this. The field is behind. There are people who are looking at this, mainly looking at it from the perspective of the processing of sensory information. So the way they do those studies is they deliver stimuli to the skin, usually, and that stimulus might just be a touch stimulus, or it might be something that's quite hot or quite cold, or it might even be a laser stimulus that I told you about before. And they look at what the brain does. And there are people who are studying that in people across neurodivergent categories. I don't think we're far enough in it to offer any really definitive answers to that question. But depending on the nature and extent of neurodivergence, then we might have to really reconsider the appropriateness of some of the treatments that we do, but also learn from some of the insights that neurodivergent people have about these things. Yeah, but I think it's a watch this space, and I think we might be watching it for a while until we get enough data to be really helpful.
What wonderful, really well answered there, Lorimer. So someone's asking as almost a follow-on with that one, if mental health has an effect on pain stimuluses.
Yeah, outstanding. Yes, absolutely. So most people who have chronic pain, if they have for long enough, they'll become depressed. They may become anxious because that's the nature of life with a chronic pain problem, depending on how much it's impacting on your meaningful activities and meaningful engagements. But for those of you who don't have chronic pain, just take a moment to think about what it might be like to have it and to wake up every day and not really know why you've got it, but know that life's going to be hard today because of it. And that is bound to affect your mood. From a biological perspective, there are neural networks that are involved in both pain and in fear and anxiety and depression and fatigue. And because of bioplasticity, the more you run those neural networks, the more effective they get at anything they're doing. So you become more likely to have reductions in your mental health if you have chronic pain. The converse is also true, that if you have significant mental health challenges, most obviously depression, then you are at a greatly elevated risk of chronic pain, because any mental health challenge that reduces your physical activity will elevate your risk for chronic pain. Those two things come together. The question was worded in a way that made me wonder whether you're thinking, if we took two people, or if we took one person into the lab and they were in a state of really good mental health, and we gave them a stimulus, and then we took them into the lab on another day when they had low mental health and gave them the same stimulus, would we tell the difference? And the answer to that question is yes, we would. We'd see a different brain response, and we'd see a different immune response and a different protective reflex response, and they would report something slightly different. We can see that even by getting people after a good night's sleep or a bad night's sleep. So all of these things matter. In fact, sleep hygiene is really important. We're understanding now. It's just really hard to change sleep. Yeah. Bit of a long-winded
Well,
answer, Ben, but
No, really, really well answered. Someone's off the back of that has asking, and obviously this won't be personal medical advice. If you can comment that their doctor has suggested that antidepressant medications can boost serotonin levels and that may assist pain relief. Is that in your kind of field commenting on that?
Look, the pharmacology is not in my field, and certainly prescription is not in my field. I'm not a medical doctor, uh, but I'm comfortable appraising evidence. So we spent a lot of time looking at the evidence base for things, and of all the medications that have been trialed for chronic pain, uh, antidepressants are probably the most effective. Having said that, they're not very effective for most people. So the best treatment, so all the evidence reviews come up with pretty consistent answers, and that is the best treatments we've got for the vast majority of chronic pain disorders are education. It's the winner in evidence reviews. Uh, and that doesn't mean reading a pamphlet. It means engaging in a process of relearning pain and how it works. Education, active and psychological self-management. So that really means movement-based approaches, um, and things like relaxation training, meditation, pacing yourself, planning ahead, these sorts of things. So they're the treatments that keep coming back in evidence reviews as the best we've got.
Someone's asking for a little bit more of a look at flare-ups, and they're asking if a flare-up is in the acute or the chronic phase.
Well, that's an easy one because the answer is yes. It's always in one phase or the other. You can have a flare up in an acute phase. Remember, in the acute phase, that's when the consequence of injury or a really active inflammatory response is changing the sensitivity of those detectors in your tissue. And those detectors in the tissues of the body, they only ever send messages saying something's changed here. That's all they say. And all of that information, when it gets to the brain starts to work out, okay, so what's the nature of the change, and is this something we should prevent? So you can have a flare up of an acute injury. You can also have flare ups in chronic pain, and most of the use of the term flare up is around chronic pain conditions. And we also use phrases like acute on chronic. But that actually makes it quite difficult from a clinical interpretation perspective, unless someone has had a new injury. They tripped over, or they had some sudden mechanical loading on their tissues, or some burn or something like that. We would normally describe these things as flare-ups, and flare-ups are when the system goes into overdrive. And normally we would say, okay, you pushed into the safety buffer a bit further than the sweet zone. And the flare up, when we used to make fridge magnets, when I used to work in Sydney, we had fridge magnets that said, don't flare up, but don't freak out if you do, because flare ups are protective. Flare ups are telling you you've gone further than the sweet zone, but you haven't gone to damage. You've gone to a big protective response. It's good to have a flare up management plan. So if you're someone who has flare ups, that are brutal and distressing for people around you, then it's good to have a flare-up management plan, just like you have a bushfire plan. So because when you're in a world of trouble, you're not going to be thinking very straight. You're not going to be able to problem solve on the spot. So if you've got something very accessible that reminds you, I'm flaring up, okay, have I had a major mechanical incident? It's the first question. If no, have I got other things going on in my life that will take up the sensitivity of my system? Nearly always the answer is yes. And the answer then is my tissues are safe. What can I do now to manage my pain in this moment while it slowly resides? And until you experience the implementation of this, you might not appreciate its power. But if I could take the liberty of telling people a story about one of the people who was trained to become a local pain educator through the Pain Revolution charity. That person is a paramedic in rural Australia, remote Australia, who a large chunk of their work on overnight calls would be people suffering a flare-up of chronic pain. And previously, she would go there, she'd give them the green whistle, they would be taken to hospital, they would be admitted for anywhere from 5 to 10 days. Uh, in learning, the course teaches these health professionals all about how pain works and how they can convey this understanding to other people. And she was telling us not that long ago that since she's got, in her words, she's got a head around the science, she goes out in the middle of the night to people in a flare-up and she talks them off the ledge of the flare-up. And she runs through this formula. Have you had a major mechanical event? No. Is there other reasons in the last few days that your system will be on red alert? Yes. Okay, well, your tissues are safe. Let's go through some breathing. Let's go through some postural or gentle movements while this flare up backs off. And she now describes that she never gives people the green whistle anymore. She never takes them to hospital because they decide in the end, actually, I don't think I need to go. So don't underestimate the power of understanding this. It's very easy to underestimate that power, and it's very easy to think that you've read a book, so you know how it works. I've read a lot of books. I've written 7 of the suckers, and I still am pretty sure I don't know how it works.
Someone's asking, how can you help or respond to when someone has been told that they've got bone-on-bone arthritis in their X-rays?
Oh my goodness, yeah, this is such a common issue around arthritis, isn't it? It's such a common phrase. It's a very, in my view, it's a very misleading phrase because it's extremely rare to have actual bone on bone because the bone immediately forms a surface for the joint to move. If your joint is immobile, you cannot move, and it's probably stuck straight, then maybe there is a chance you got bone on bone. I think the way to respond to that is to recognize what that phrase might mean for that person. And it is a really high threat phrase. And maybe rather than try and correct it, because maybe it might be that very rare situation, you might be able to suggest learning more about ways that you can help that, let's say it's a knee, you can help that knee be less painful and more mobile, and learn about how arthritis works. It's a really challenging one, and as I listen to that answer, I'm a little bit dissatisfied with it myself, uh, because it's so hard, particularly if that information has come from someone who has a very highly weighted opinion. Like if it's come from a health professional or a surgeon or something like that. But it's worth looking around for contemporary resources around arthritis. I mean, I don't want to plug our stuff too much, but our knee OA handbook has some really interesting stuff around this in it, and the relationship between X-ray findings and symptoms. Bone on bone is nearly always an interpretation of an X-ray or a scan. Uh, and really, you can't make that clear interpretation. And there are people who have scans that look like that who are relatively pain-free. And there are people who have horrible pain with excellent looking scans. So the situation is tricky. I recognize that. But I guess the most important thing is to validate the experience of what's it like to think that and sit alongside people for their learning journey.
Now, I'll jump on the back of that as well as 2 people that Lorimer's worked with quite a lot, which is Tasha Stanton and Felicity Braithwaite, who have very kindly both done webinars about and covered that topic about very much about bone on bone and scanning and the wear and tear myths and things like that. So if anyone who's asking that question and wants to learn more about kind of those myths and things that we can do to help that, we've got webinars in our back catalogue that really address those two things as well. So someone's asking, Lorimer, if you've got a little bit more time, what are some of the tips, as you mentioned, if you've got any for, you talked about sleep and sleep hygiene. Are there any tips you can kind of give someone for sleeping better, especially maybe when they're in a flare-up or in pain?
Uh, I'm no expert on sleep tips, and I happen to have been blessed with a world champion level of sleep aptitude. So I don't have any lived experience of this, but the beautiful Anna, with whom I share my life, is a psychologist who works a lot in this area with clients with a whole range of challenges. And I hate to give it a rudimentary job, but the things that are pretty intuitive. Don't get on your phone last thing at bed or the computer last thing at bed. Don't watch TV in bed. Have regular sleep times. Stay awake during the day. Don't eat your meal last thing before you go to bed. These sorts of things. There are some, and I know evidence, right? But I don't work with people towards improving their sleep habits. But there are a lot of resources out there around that and ways to help you relax. And Smiling Mind, I think, is an app that's well regarded. Yeah, so I'm not the most credible person to answer that question.
No worries. And I will say as well, we do have a webinar in the back catalogue too, all about arthritis and sleep and how arthritis might be affecting people's sleep and things they can put in place to help that as well. So but we're lucky we've got some fantastic experts in South Australia, much like Lorimer. And the last one that I'll ask for tonight is someone asking about chronic pain from an autoimmune inflammatory type of arthritis. And they're saying that they've been told it's degenerative and that they've had consistent surgeries required to fix the joints, the ligaments, and tendon. Can this still be helped with this system?
Yeah, that's a great question. So in the early days of exploring the usefulness of an education-based approach to improving the lives of people with chronic pain, there were a few diagnostic groups that tried it. So different types of pain conditions, and the obvious suspects were people with back pain, headaches, neck pain, shoulder pain, knee pain, fibromyalgia. But the group that reported the most benefit of understanding and then operationalizing, then learning the skills to work their protectometer, was the group diagnosed with rheumatoid arthritis, and that's one of the autoimmune conditions that, if uncontrolled, will end up in a situation like the person has described. The principles, those essential pain facts, apply to humans almost regardless of their situation. It's just that in some, for example, autoimmune conditions, damage is occurring, and the primary goal in medical management is often to stop the damage occurring. So those classes of drugs that interrupt the inflammatory cascade. But the principles of bioplasticity, the essential pain facts, they all still apply. And if you have persistent pain around an autoimmune inflammatory condition, you're still overprotected. So there are still many ways that you can influence your pain, and you can do that alongside the best evidence-based strategies to limit and reduce damage. The approach of education heavy has been trialled in surgery, post-surgical patients, pre-surgical patients, palliative care pain patients, and so far no group seems to buck the trend of getting benefit out of deeper understanding and using the skills and strategies that understanding tells us should work.
Wonderful. I think that's a fantastic message to end on. So thank you very much for everyone for spending your night with us. And thank you very much, Lorimer, for presenting with us. We greatly appreciate it. And I hope everyone enjoys the rest of their night.
See you later. Thanks a lot for having me. Go well, everyone. Enjoy your evening.